I'd like to welcome everybody to the quarterly meeting of the Mississippi State Board of Health. Our agency does extraordinary work, and they're continued in the battle to take care of Mississippi citizens. I did want to recognize two new members, Dr. Rick Carlton and Benny Hubbard. Outstanding citizens in the state, and they're going to contribute a lot, and I expect a lot. And after the opening prayer and pledge of allegiance, we will swear them in. Why don't we go ahead and get the opening prayer and pledge of allegiance done? Moody, do you mind giving our opening prayer?
I would love to. Lord, we thank you for this opportunity that you give us to serve the people of Mississippi. Lord, we just pray that as we go about our daily tasks, that someone will see some good out of the things that we do. Lord, we just pray that each and everything that we say or do today will be in accordance with your will. Lord, we thank you most of all for your love, your mercy, and your grace that you show to us each and every day that you allow us to live in your world. Lord, we just ask for your concerns and blessings for the people of Israel and others, Lord, that are under siege at this time. Thank you most of all for sending your son Jesus into the world, that through our belief in him we might have life and have it everlasting. These things I ask in Jesus' precious name. Amen.
Everyone would stand for the pledge of allegiance. Pledge of allegiance
to the flag of the United States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
I would like to recognize Senator Hob Bryan, who is one of the champions of public health in Mississippi. And not only is he a champion today, but he's been a champion for, will you forgive me for saying decades? Does that speak to your age, Hob? He's one of the brightest minds in the Senate, and I'm glad he's exerting that mind to help healthcare in our state. You mind giving a few comments? Should I do that? Wherever you feel comfortable. Why don't you come right in front of us? Because I'd like the Board of Health members to see you so they can. Yes, you're a better target right there. I did want to say thank you all for and think about all over the this the first Board of Health they never got to change Since you're wearing tennis shoes, you can run to the door when you have to leave, but you have permission to leave whenever you'd like. Thank you, Senator Bryan. Mr. Moody, you've been in the legislature once or twice, haven't you?
Well, I was there a few times, and you know, it was my pleasure to serve opposite Senator Bryan. He always had the interest of the healthcare of the citizens in Mississippi. That wasn't to say he and I had a different approach to how we got there sometimes, but we never left that room hating each other. We might have disagreed on how we were going to accomplish what we had in mind, but we always come out with a way to solve our problems.
And that speaks to his political integrity and your political integrity. We appreciate both of you. The next thing on the agenda is the induction of our new Board of Health members. Is this done with them together? Do they just need to stand up?
Yes, and the court will swear them in.
Our court reporter, she has also served this board and this department for a long time. It's been like herding cats, hasn't it? Since 1985. Welcome, gentlemen. And this entire board is one of the finest boards in the history of the Board of Health. And I think there's a lot of talent here, but much is expected of us. We're going to be working with the state health plan, trying to make it more strategic and helpful in serving the citizens of the state. And I think we've got a team in this board that can really accomplish a lot. We are planning a board development meeting in January. So our January, which is our next quarterly meeting, we'll be meeting a little earlier at like 8:30, I think is what we're planning. Dr. Anthony may remember we have the same facilitator, Tim Fallon, who is going to lead us with some board development and strategic planning before the meeting. And we'll do that in the morning. And then we'll have our board meeting probably at 1. And that way we'll still be able to get through hopefully by 2 or 3:30. But do plan for the January meeting. It's very important for everybody to be there. And we're scheduling it on the day of the quarterly meeting. So your attendance won't be another date. But as Dr. Anthony can attest, this facilitator is outstanding. He'll bring the board together. He'll also help if areas are of specific importance to y'all that we're not addressing. It'll be a great time for us to speak to those issues in a setting where it's just the board. And we look forward to that. And we'll get you more information about that, but do plan for the January meeting to start a little earlier and last a little longer. The next item on the agenda is approval of the minutes. Are there any corrections with the minutes? And they are before you. If not, is there a motion to approve the minutes? There's a motion by Dr. Davis and a second by Dr. Anthony. All in favor say aye.
Aye.
Any opposed? All right. Now it is time for the state health officer's report. Dr. Edney.
Thank you, Mr. Chairman, and good morning, board members. We've had a busy few months, a lot on our plates, and very proud of the good work that the team has done, moving us down the road. We've had some heavy lift issues, but making progress across all fronts. I'm pleased to report. We'll start this morning. Dr. Taylor will give to you the current epidemiological report and be happy to answer any questions for us. Go ahead, Dr. Taylor.
Thanks, Dr. So there's really just a couple of main things that I want to talk about, but I'm also happy to answer any questions that you have. So the first thing is respiratory virus season. We're in it. In the past, we would have worried mostly about flu, and then 3.5 years ago, we started worrying about COVID, and RSV has started rearing its head as well. So those three together have the potential to cause us trouble, especially if we have severe symptoms of all three. So at the health department, we monitor COVID-like illness and influenza-like illness pretty regularly, and we're working to get RSV monitoring up to date a little more. I'm also going to talk about vaccine updates and then a little update on congenital symptoms. Next slide. So we post a weekly update for the COVID-like illness, which is blue, and the flu-like illness, which is orange. And basically what that is in our syndromic surveillance network, we have many urgent cares and emergency rooms who report syndromic data to us. So this is a collection of people who are presenting with symptoms consistent with COVID or symptoms consistent with flu. And it also includes diagnostic codes for COVID or flu. And so you can see over the last few months, we've had a little bit of a peak of both COVID and flu. COVID's come down, flu came down and then sort of plateaued. And that's consistent with what we're hearing. We're still hearing some cases of COVID. We're still hearing about flu. And we'll continue monitoring that. For perspective, that peak of COVID is still much lower than when we had the Omicron peak. So we definitely want to avoid that, but it's not gone. It's causing less trouble with hospitalization, but it's still for sure around. Next slide. So for vaccines, flu shots get updated every year. COVID, it looks like, is moving that way too. The public health emergency for COVID ended in May on the 11th. And since then, there's been a move to sort of hold COVID into normal medical care. And part of that is making COVID vaccines commercial, which means health insurance will cover them. And so CDC has created a bridge access program for those uninsured and underinsured individuals who wouldn't be able to get the COVID vaccine due to cost because they didn't have health insurance. So the updated COVID vaccine for 23-24 is now available at many pharmacies. The health department is also giving vaccines to those who are uninsured and underinsured as well. So it's available. The general recommendation for almost everyone is basically get an updated COVID shot. It gets a little more complicated for those under 5 and if you're immunocompromised, but in general, it's basically you need an updated shot regardless of how many you've had before. This year is really exciting too. We have RSV vaccines and prevention products kind of for the first time in a long time ever, something new in the respiratory world. So there are 3 I want to talk about. One is a vaccine for adults 60 and older. It's open to anyone. It's a shared clinical decision-making with your doctor. So if you're interested, particularly if you're high risk, definitely worth looking into. There's also a vaccine for pregnant individuals who are going to be between 32 and 36 weeks gestation during RSV season. And that's to protect the newborn. There's also a monoclonal antibody product. So you may be familiar with this from the monoclonal antibodies with COVID. It's sort of a temporary immunity. It's not a vaccine, but this is available for kids. It's recommended for basically all kids up to 8 months. And then for those 8 months to 19 months, it's recommended for certain high-risk kids. So those are approved now. They're not yet available to be ordered. So we're hoping that they will sort of be available to order later this month. If y'all are interested, we can give you an update on that later. But really excited about those options. And then the last slide is kind of a quick update on congenital syphilis. So we've been talking to you guys since Dr. Byers first mentioned it, I think in April. That's when we made the emergency change to require syphilis testing and reporting. One of the things that happened out of that is that we made it a requirement for healthcare providers to call the Department of Health when there was a positive syphilis test in a pregnant individual. Previously, those reports would sometimes get called in, but more often they would come in via electronic lab reporting or a fax lab report. And I don't know how often you look at all the demographics on a lab report, but very rarely does it say that the pregnancy status on there. And so having those called in means that we're aware of the cases that are pregnant, and we can make sure to do our investigation and ensure treatment prior to delivery. And so if you look at this is the number of congenital syphilis cases over the last few years. When I spoke to you in July, the 2022 cases were not completely validated yet. But even in the little bit of awareness we had at that point in time, you can see the rate of rise has changed. So we had a pretty big jump from 2020 to 2021, less of a jump, but still a jump, unfortunately, from 2021 to 22. And then this year so far to date, we've had 33. So how we count a congenital syphilis case requires a little bit of additional investigation. So that number is likely to change further. But the number of calls we're getting for reports and the buy-in from providers to make sure that their patients are treated, they're following up to say, hey, this is positive. Were they ever treated? Do I need to treat them again? I have high hopes that that number will start to go down. Going down is the first step. Getting very, very close to zero is where we're gonna. So that's all that I have, unless y'all have some questions.
One question, mentioned the availability of the vaccine for pregnancy during RSV season. Now, what would be RSV season?
That depends a little bit on where you live, but typically it's going to be kind of the fall and early winter.
Yeah, and then the requirement for calling for syphilis testing, that's confirmed, not just a positive screen.
It's a positive test. If it's in a pregnant woman, we would really love for people to call immediately so that we can help look up some background information and find out, is it a positive initial test and they've been treated before, and so we're probably pretty good, or getting us information sooner is better. But it's definitely for cases is the requirement. But please call us as soon as you're even concerned.
Yeah, but
are having a false positive and have been treated before. So we don't mind phone calls. The STD HIV program is more than happy to answer phone calls and answer questions and look up historical data for healthcare providers that call and that are caring for pregnant individuals, because we would rather answer 100 unnecessary phone calls than miss the one. So definitely the message is call first and then worry whether you should have later, for sure. Yes, sir.
How is the RSV monoclonal antibody administered to infants?
It's an injection.
IM injection.
Dr. Taylor, you might have said this in phone, so I apologize. Did we just not track in 2018 or 2019, or was there just an explosion?
So the tracking before 2020 was including only confirmed cases.
Okay.
So CDC case definitions typically have a confirmed case definition, which is a little more stringent, and then a probable case definition, which is a little more loose. And so in 2020, we started counting both in our tracking because we wanted to be a little more thorough and make sure we knew exactly the total picture of what was going on.
Now I'm a little sorry.
Yeah, sorry, it's really small.
And then my second question is there a specific area of the state where we're seeing these cases? Like, are they concentrated in the Jackson area or the South Haven, or are they kind of all over?
It's a little bit of both. So it is a little all over the place, but it's concentrated more in population centers. But I mean, 33 this year, so concentrated is kind of a loose term. But we are seeing more syphilis in general, and so part of this is to make sure that the pregnant women are seen and treated as quickly as possible. And the other piece of that is to make sure there's less syphilis overall. So we're working both angles, but the one that seems to be bearing fruit the fastest is that communication between healthcare providers and our department to make sure we're aware of where the cases are so we can jump on them.
So Dr. Taylor, it appears we're seeing a little trend, maybe positive with syphilis numbers, but there's still a lot of it out there. There's a lot of work to be done. Is that what you're telling us?
Yes, sir.
All right, what other questions do we have for Dr. Taylor? We appreciate the work you do. Thank you.
Thanks, Katie. And Mr. Chairman, if you'll allow, I'll have Logan Dillon, our governmental affairs officer, come up and just go through the legislative update for you, which will help with the consent
Please.
agenda.
Morning, Mr. Chairman, members of the board, thank y'all for letting me speak to you this morning. We have 5 items of legislative draft discussion. The first item is our annual choice of law and recommendation. As you can see, this year we have different items. We have one item that that's recommended to be placed in Schedule 4, one item for Schedule 5, 7 items for Schedule 1, and removal of one from schedule. Next item is currently we're undergoing the renovation and repair of the Underwood building. Today, we've received 2 different pots of money from the 2021 session and 2022 session. Right now, our current estimates that we need a remainder of nearly $21 million to finish the project. That's our current estimate today. Next item is every year we make a request for the rural water revolving loan fund. Last year, we received the full amount requested. This year, we're requesting $7.3 million. That comes with a 5-to-1 federal match. So it's estimated that if we receive the work, it should be somewhere around $36.5 million. And then finally, this year we have 2 public health feelers with our code section. One has to do with Harvard Racing Law, and the other has to do with the State Board of Health powers and duties, which establishes the State Department of Health. This is all right. We're having questions.
Any questions? Mr. Perry?
Thanks, Logan. And I'm going to suggest this when we get to the item 15 agenda. On the 2 items where you're requesting funding for the facilities. I do think that what our request should be the funding rather than the mechanism for the funding, because the way that the legislature's been funding all these projects recently, capital expense fund, and not having. So I just think that we ought to request the funding either through appropriation or general obligation bonds, not specify, it shouldn't be our position formally to request. So, yes, sir. Bond. So when we get to that point of the agenda, I would suggest pulling that out. Record what we're actually asking. And then second, I would like to add to our legislative agenda the board's position that they involve further changes to the cannabis. It's we spent more than an hour this morning cannabis committee. There was pretty substantial. We had a very quick ramp up for a program that's very complex. The legislature came back in the last legislative session and made more changes. We need to have some consistency to figure out how this is really working. Before we make even more changes, they're going to put a new round of regulations in place for 2 reasons. One, staff here needs to be able to have some period of time to know what it is that we're doing. And second, people that we're regulating need to have some sort of consistency of what we're doing. And let's at least get through a year of something before we make changes. And I think that should be our official legislative agenda.
What other questions for Logan? Logan, if we can get this though, we're going to be bringing a lot of people back here, right? This will allow us to have more people working out of Underwood.
Yes, sir.
Yes, Mr. Chairman, our plan is for the pharmacy to be brought on campus, which is desperately needed. If you know where the pharmacy is. And, but also, I mean, we have significant square footage limitation and we need that square footage in service. And there's no way, I mean, we continue to have serious infrastructure problems with that part of it. We have it with this building, which is much younger. And this is not a new ask. This is, phase one has been funded. This is for phase two. And, we put it before them and they're aware of it. DFA is aware of it. We just have to keep putting it before them until it's officially approved. I agree with Mr. Perry. It's, I think we should get the bond language out of the way. However they choose to do it, we'll be grateful. I do want y'all to be aware, I think if you rode the elevators this morning, we have significant problems with this building. The roof is leaking terribly. If you come in my office, there's a garbage can right in the center of my office catching water, and the elevators are a struggle. It's just the building's aging out. We're having to invest significant agency resources into the building just to stabilize things. We definitely have need.
All right. What other questions for Logan? Thank you, Logan. Appreciate it.
Thanks, Logan. All right, and going on with the report quickly, I want to break things down into two main areas. We have our area of population health, and then our area of agency operations and strategic thinking in terms of the agency itself. So from a population health, the biggest announcement that we have for y'all is that yesterday I had the privilege of signing the Uber contract. So we now officially have a contract in place to provide transportation to and from the county health departments for those who lack transportation resources. And that is a major issue. It's a major social determinant of health that impacts people getting anywhere they need to go. But we have a 50% no-show rate in the county health department clinics, despite really working, to make sure people are coming and are aware, and it's fairly routine that at the last minute they just can't get to us. So this contract, which is through the use of federal funds, will allow us to bring patients to and from our clinical operations. And then as we strategically look at providing core public health at the community level, the transportation services will give us a lot of options in terms of how we go forward. And very grateful, Dr. Victor Sutton and his team did an amazing job, fairly heavy lift. And several other state agencies have been watching as we went through this, and the contract is designed so other state agencies that have the same problems can take advantage of it. And I think you'll see a little bit of economic development happening as, counties all over the state will need Uber drivers, and we'll have funding for that. So very, very pleased with that. As we continue with our number one priority in population health being the reduction of maternal infant mortality. Y'all know how much attention that is getting. It's not just attention on us, but this is a nationwide issue. And we continue putting our emphasis into the Healthy Moms, Healthy Babies, high risk maternal infant program for our high risk Medicaid population. That program continues to mature and develop. It's resource intensive, and but there is interest to look at some state-directed funding, as has occurred in other states. The Medicaid reimbursement will not fund the program. It won't be sustainable just based off Medicaid reimbursement, but this is, this is a key part where evidence-based practices are moving the needle in other states, especially Georgia. They really put the positive factor for them, reducing maternal infant death on their home visitation program. So, following the evidence is really important, what other states are doing. And then, as we've been discussing, and you have endorsed, the developing the new obstetrical system of care, working in the Mississippi Delta. There is a lot of interest outside of Mississippi in what we're looking at. A lot of interest in the Delta for an opportunity to help communities with this need through our system of care. Again, this is evidence-based. Not only evidence-based in terms of the maternal levels of care, but also we have a long track record going all the way back to the initiation of our trauma system of a lot of experience in this agency, working with our partners, especially at the Mississippi Healthcare Alliance, to do a good job with systems of care. And what's really getting attention from other states is how we are bringing the two together. There are only 10 states that are doing a mandatory designation of maternal levels. Those states also do a regional approach to transfers. We'll be the first state to go that next step and put the entire package of a full system of care, from point of contact with 911 to the ER in the hospital. That we really will be the only ones. So we've actually been invited to present our strategy before a national public health group later this month. And, it's wonderful to have attention coming for a positive thing. And, it's exciting to me just looking at, we follow the evidence, but we do it in innovative ways. And so I really think that's going to be a game changer as we roll that out. We have our agreements in place with Mississippi Healthcare Alliance, and we're moving forward with that partnership. From a population health standpoint, we lead the nation in preventable deaths, and we have the lowest life expectancy. And a lot of that impact comes from chronic illnesses. So we had announced to y'all that we were rolling out access to free blood pressure and blood sugar screenings in all the county health departments, and that program is going. And I told folks we need to make it as easy as going in to Walmart and using the blood pressure machine there. It's not coming in to check in and be a patient. It's coming in and just having your blood pressure checked. And then we have protocols if it's outside of expected range, then how to connect them with proper services. The same thing for blood sugars. We are catching hypertensive diabetics too far downstream at this point. So this is just one thing we're doing to get a little bit further upstream. We still have a lot more to do, but I'm very, very proud of that program. And then to remind y'all that October is Breast Cancer Awareness Month, and the Breast and Cervical Cancer Prevention Program is a wonderful program in the health departments where all women have access to mammography. Our uninsured women, if it's appropriate for screening, then the BCCP program will pay for their mammogram. If it's abnormal, it will pay for their workup. And if we find cancer, then they immediately qualify for Medicaid. So very unique, wonderful program that provides access to screening services for our uninsured women and also for cervical cancer screening. So just a reminder with that program. At the agency level, as I have discussed with y'all before, the improvement of our clinical operations is an agency imperative. This is our as I see it, our path to financial sustainability as well as improved provision of care. And we continue in that work. You know, I think I shared with y'all that we generated 4 million more in our revenue generation than we had previously. And as y'all know, Dr. Dobbs really kick-started our revenue cycle work, and we are just growing it. So Dr. Young and her team are really helping us move forward, and we still have a lot of opportunity ahead of us. And I think there is still significant financial opportunity for us there. We'll continue to work to generate that. And what is going to really help us with that, not only is transportation, but our telehealth program, which is steadily rolling out. That's one of the issues when you have 86 county health departments. You know, there's a bunch of moving parts, and they're all in counties with all different resources and opportunities. But Dr. Young shared with me earlier this week that we have basically gone from virtually no telehealth appointments up to 80 for next week. So still, you know, a lot more room for growth there, but it's a good start, and it's, you know, way better than where we were. And as I watch those telehealth visits go up, then you will watch clinical revenue go up with it, because the more we can get off public health protocol, which are RNs just doing the checklist, over to a provider encounter, a person at telehealth, and that becomes a billable encounter for the same work and the same service, but we're able to generate billing to Medicaid and other third-party payers, and to use those resources back into our clinical operations. So that we're making good progress there. Our legislative assignments are going well. We finally have gotten past the impasse of compliance that grant. We've been working since May, just trying to, with our compliance officers at HRK and Horn, to get us to a point where we could fund the maximum number of hospitals to the maximum extent possible as allowed by ARPA. Things are looking much better, and that's going to be happening this week. Our AED program, the automatic external defibrillators, is going well. Those grants are open, and I would encourage if you have any relationships in school systems, public school or charter school systems, to have them take advantage of that. Basically, they acquire the AED and send the invoice to us, and we reimburse them from those grant dollars, which are state resources. Makes it real easy. And the Burn Center grants are for UMC and Baptist Hospital, our two designated burn centers in the state, are open, and we've been in communication with both hospitals. Everybody's in agreement how we're handling things, and we're just waiting for invoices to start reimbursing those hospitals off that grant. And we have been spending a lot of time with the early intervention program, working with the task force. Chris Hancock, our senior deputy, is running point on early intervention for us now, and Dr. Sutton has stepped up for health services. And together, you know, that wonderful program that serves the needs of our children with special needs is moving in a very healthy direction. I'm very positive and optimistic the work coming out of the task force and the cooperation of our team with them. I do want, with the state health plan, things are going well there. HMA was in town Monday and Tuesday, doing interviews that they've been focusing on board members up to this point and elected leadership. And they were doing more of those interviews this week. And I think very soon they'll be moving to community partners and stakeholders. So as you have those that you think should have input into the state health plan work, let me know so we can refer those organizations forward, and we'll keep you apprised at that point. I'm getting a lot of good interest from elected leadership and good questions, and everybody's kind of getting the picture and buying into it. The new priority, as I see it, that's needed for the agency is to raise the awareness with emergency medical services. And I think we all know the stress that the system currently is under. And I only see more stress coming on it over the next 5 years as more hospitals become rural emergency hospitals, and there's more need for transportation between hospitals. And then also as systems of care, which are things we have to do, population health, but they are labor intensive on EMS as well. So I think there will be some advocacy at the legislature about EMS. What I'm doing, since Dr. Carlton was appointed to the Board of Health, the downside of that is he has run the EMS Advisory Council for a long time. And what I'm doing, specifically with that advisory council, Dr. Carlton, the chair of that is the state health officer or his or her designee. And for a short while, until I really have better understanding, I'm actually going to serve in the chair position and work with that council and make sure I understand our, the professional opinion of our experts, and let us come to a consensus of really what we need to do to help EMS, and then kind of see who best to appoint as my designee there. But I want to thank you so much for your decades of service in that space. This is going to be really helpful at the board level, and we'll be leaning on you.
Well, to have it, it was one of the most enjoyable things that I have done because of the commitment of paramedics, and we just got to come up with a way to recruit them and retain them. And then, like, we are going to continue to increase their responsibilities with our systems of care, because I can see 2 or 3 more coming down the road that will just strain the system further if we don't get this addressed.
Yeah, I totally agree. And, the things that we can do really fall within licensure and regulatory action, but we need to do all that we can at the agency, but then also the advocacy component that we can do as partners of asking for help from the legislature.
Right. So EMS is facing, is it a critical, it's become at a critical stage, and then there's not enough reimbursement? Is the system not really having the money to operate as well?
You're right on both counts. There's we have decreasing numbers of individuals entering paramedicine, and at the same time, we're increasing the need for paramedics with all of our systems of care, which are improving the care of people in Mississippi, which is what the whole thing was oriented for in the first place, as far as our systems of care. But the margin of profit, and I hate to think about things in terms like that, but for services, whether they're hospital based or private, is so low that they are somewhat limited on what they are able to do and what they are able to pay paramedics for performing the work. So it gets, it's like, it's the chicken or the egg sometimes that you're pursuing. But one of our biggest problems is getting people to enter the field. And then it also seems to be something that's more for younger people. You rarely see older people because of back injuries, shoulder injuries, that kind of thing. And we could talk about this later, but that's why I favor having some other avenues that older paramedics can still stay involved. Maybe work a little bit as a paramedic, but have some other outlets where they can work that would help at least keep them in the field, no pun intended, a little bit, but just not as much as they were when they were 25.
You anticipate the legislature exploring this issue further?
There are some legislative champions that I've been meeting with that, and I know EMS community stakeholders have an agenda that have, that will, uh, support with data and advocacy as if it's moving in the right direction, as Dr. Carlton is talking about. Uh, and I think most of what we can do, we can actually do through regulation ourselves. And then I think the legislature will have to think through how do we solve the problem of EMS. It's already really stressed, and we can't afford for that system to fail.
So our council and legislature be doing things that we as a board just kind of let y'all bring us.
Yes. Yeah, we don't have a legislative ask from EMS, but I mean, it could come out of the advisory council, and if it did, that would be something. If it were significant, we'd bring before you in January to get the board's opinion. But right now, I don't know of anything.
Right. But just so that you know, Mr. Chairman, in addition to what we're already asking to do with STEMI and stroke and trauma, during COVID, we had a system where patients were distributed because of saturation problems and the inability to get patients transferred. We are having a major problem getting patients transferred because of the hospital saturation. And so services are oftentimes having to transport out of state, and sometimes a couple of states before they can find a hospital able to accept the patient. So that's an additional burden on them. And then if we roll in OB or perinatal system of care, and sepsis is being developed, all of a sudden you can see the potential for markedly increasing the burden on EMS.
Yeah, that's why we have to be thoughtful through these issues.
Is there like in career and technical education in high school, is there a paramedical emphasis? Is it mostly like nursing and that sort of thing?
Yeah, I like the way you think. We have started doing some of that locally, but I don't think statewide there's a major emphasis on that. There needs to be, currently, and there are pros and cons. We were really happy several years ago when we moved EMS to an associate's degree where the community colleges basically took it over. But then that at the same time contracted the number of people that were going into paramedicine. So I'm partly to blame for some of that. I'll take that responsibility. The quality of the medic is far better. And so, you get into, is it better to have someone less trained if they at least have a paramedic? Those are some issues that we're going to have to struggle with. But I think going into the high schools around the state and making them more familiar with it is something, and that's going to have to be done very much at the local level.
So board, this is an issue we'll need to be paying attention to.
And Mr. Chairman, that is all I have for the health officer's report. If
On the hospital program, said that got some clarity in the last week or so. What's changed?
we have been working to get the eligibility criteria to the right place so that the maximum number of hospitals could be deemed eligible through ARPA and yet remain ARPA compliant. And that's been the balancing act between us bringing forth recommendations or potential criteria and then going through the compliance process. What has happened now is that we have had approval that happened just really in the last few days of expanded criteria, giving the hospitals more options, and actually adding an extra year option that still falls within the guidelines. The more broadly you go, the more at risk of audit you are. So the compliance folks trying to hit it, just trying to find that sweet spot of what will give the most funding to hospitals and yet keep everybody compliant from federal audit.
Approval from who?
Well, our compliance folks for ARPA and HRK, and Horn has the ultimate authority working with DFA. DFA has control and responsibility for the ARPA funds. And then as different agencies are working like we are in our space, then we have our own regulators, compliance, CPA guys who work with us directly, and then they have to work with Horn, but Horn has to give the ultimate approval.
Well, I would think that an outside, I mean, Warren has a bunch of really good, but they're a contractor. They shouldn't have ultimate authority. I would think that whoever manages the contract, or, right?
DFA has ultimate
DFA,
authority, right?
So and I completely understand that, DFA and state, because we're gonna be responsible for paying back the ARPA money, if it's not spent correctly, that they have a very good. Just make sure that I understand, we've been working with I know that DFA and the health department suggested to the legislature session that the ARPA bucket is not correct bucket in order to get maximum flexibility. But so just to make sure we understand that what's been going on the last number of months is that DFA and the health department have been trying to figure out how to put square peg into the round hole of ARPA, and working with outside consultants like HRK and Horn to figure out what would minimize or mitigate the risk of payment, financial challenges in the state.
That is exactly right. And for those who listen and get that, we have to do it right in the front end, or it's a disaster on the back end. And it's important for us to protect the hospitals by having the compliance piece right. So because there's a lot of appetite on these COVID funds for clawback. And so it's a really sensitive time that we don't want the feds pulling dollars out of hospitals, or certainly out of us.
So you're saying though that there seems to be a meeting of the minds between health, DFA, and to the extent the HRK and Horn at outside consultants are giving their recommendation that it could mitigate risk. Does that mean that when do you think money will be flowing, recognizing that it's a reimbursement for past expenses?
Yeah, and actually that was another win, was getting it from a reimbursement model to a beneficiary model. So all we have to do is get them eligible. The big factor is we have to document negative impact. And it has to be negative impact that was not satisfied by another federal program. So we have a lot of hospitals that had negative impact, but they got enough Stafford funds or other federal funds that eliminated that on the books. And that's what we have to go by. The expanded
duplication of benefits.
Yes, and the expanded criteria are allowing them to legitimately report data that we need that shows the true negative impact that they have been suffering, but in a way that ARPA, can satisfy. And I think y'all know me well enough. I'm not signing any awards until I have it in writing, from the compliance guys that what we're, the criteria that we're following, and actually, they do the scores for us, is absolutely ARPA compliant. So I will have that in writing. And then we have 6 hospitals right now that we've just been waiting so that we could activate the program, and award letters are ready to go out just as soon as we get that document that I'm waiting on from HRK. And then we have 40 more right behind them. And that's just from the hospitals with the expanded criteria, the numbers we currently have without changing anything. The eligibility is going to jump up significantly. And then we're going to work, with each hospital that has applied to see if we can legitimately, legally get them eligible to the way the program is designed, and help them do that. And we think at the end of the day, we should, and this is according to the auditors, we should get to 85%.
So I would think that there's gonna be, based, what I'm hearing you say is there's gonna be a certain amount of money that can go out fairly quick, and then it's gonna slow down to try to get to the 85%, the 85% of greater, or whatever it is. When do you think those six that you're talking about, I'm not sure what six are, but I guess, when do you think the six will be getting money, and when do you think the next 40?
First step is to send the award letter out, and as soon as they sign it, send it back. DFA is on standby to drop the funds, and I want everybody to hear Liz Welch and the DFA team have been great. I mean, really, they have not been obstructionists, but they're doing their job.
They have a, DFA has a almost impossible task. It's the way that, with the task, the mandate that they have is to not have the federal government saying, come write us a check for $100+ million, because you decided to do something.
Right.
And managing at the same time, trying to get money out the door. I mean, I think they've done a great job, but, and I Charlie agree that Horn and HRK are, they're doing their job to protect us well. But at the same time, we have this legislative intent, and there's a demonstrated, maybe not for all the hospitals, but start to really money pretty quick. So when do you think that
Our part on the first 6 hospitals will be done by tomorrow. I mean, very quickly. We get that document. And it's not just me wanting it, but it's also legislative leadership wanting it. And because there has been a reversal. So we want it in writing. And then the
reversal by whom?
of the opinion related to the expanded criteria.
Okay, so who changed their?
It would be a combination of both HRK and Horn.
Okay.
But again, nothing happens until Horn tells DFA it's okay. But the reversal came about because of seeing what some other states had done and seeing some compliance, being favorable, and other programs in other states doing what we're trying to do.
Okay.
And so that, Lord, I wish we'd had that 3 months ago, but we got it today. And so we're ready on our part to push funding out. We think within 2 weeks, Chris, the group behind them, which is moving through fairly quickly, I think within the next 2 weeks, we'll have, a lot of money out as we continue to work, trying to get everybody possible, up to eligibility. And then, some people are having eligibility and some residual need, but it's nothing close to their cap. But we want to try to get their need legitimately documented as large as we can, so we can get as much of the ARPA money as we can out.
No, I really appreciate what you and the staff, DFA, and all the outside contractors work with. But I have some personal experience of trying to create a program using federal dollars for something that wasn't necessarily originally intended for, and it's not something that can be done in a day or a week. There's a lot of back and forth and trying to get guidance and clarity from the government, which is not something that happens easily. I know that everybody who is counting on that money thought that the legislation passed, said check. That's hyperbole to make, but I mean, it's harder than that. So I appreciate it. But now that we have a little bit of a path,
Yeah, I mean, believe me, I was talking to Kim Hoover at MHA yesterday, updating, making sure everybody's on the same page. And first thing I said, it will be a glorious day when I get y'all this money. Get one thing off our plate. But I do think, Mr. Berry, that within the first round, it's going to capture a lot of the most intense need. And then, we'll keep working the problem until we get where we need to be.
So that should help a lot of our struggling hospitals, but there still is a significant problem next year and the year after that.
I do think the enhanced MHAP Medicaid program is going to be very, very helpful. I think the combination of the two, I kind of look at the sustainability grant being kind of like some immediate rescue to help them until the enhanced MHAP money comes down from Medicaid. I think the two together would be very helpful for the hospitals.
Well, I think that hopefully that and two other things. One, I think there is an increased focus on the commercial reimbursement rates, which will dovetail with the enhanced Medicaid. Second, I do hope that the work that we're trying to work with the state health plan can perhaps put a little bit more focus on what long-term would help find the need as opposed to for example, the way this program was originally structured of we're going to give out money based on license capacity, but usage, etc. Maybe to be a little more of a long-term model as opposed to a short-term.
And it's definitely helpful for the rural hospital situation, but both programs actually benefit the larger metropolitan hospitals more, but they benefit everybody. So we need to benefit everybody, but it's still certain areas of the state, rural hospitals are still going to be struggling. But this is going to help a lot. We're going to be in much better shape 2 years from now than we've been the last 2 years, I would say. So, any other questions, Mr. Chairman?
What other questions for Dr. Edney? He's answered a lot already.
Are a significant number of our school systems making themselves available of defibrillators?
We've had, Melissa, 40, around 40, not, the beginning, not enough. I've actually asked Dr. Turner, Chief Medical Officer, to start reaching out to school districts that we've not been hearing from. And we've been pushing an awareness campaign. State Medical has helped us with that, but we just want to get the word out to school systems. It has to be public or charter, but according to the statute. But if y'all have relationships with school systems, let them know, because we want them to get a free defibrillator.
But the program would not be available, say, for private schools.
I think the statute with specific public and charter was with the statute that was given to us.
If you're running something back, is that in-house or outsourced?
It's in-house. But Mr. Herbert, I'm looking at all options. No offense, Darcy, I'm looking at all options.
Is there a question?
A quick question about the defibrillator. So the schools would get reimbursed for the actual defibrillator, but would they get any training on how to use it? Or is that part of the grant too, or is it just the?
Well, listen,
I think it's worth noting that, as you mentioned, the fact that a lot of the money from the Medicaid change, Medicaid reimbursement go to some of the larger systems in our larger metro areas. That has a profound impact on here, Mississippi and rural Mississippi as well.
Yes.
We talked about the issues we have with EMS, the ability to safe transport patients, have capacity. Discussion about having to send patients literally out of state speaks to the capacity issue in the larger health system. If there is not a bed staffed by a nurse, that transfer meaningless. That theoretically transfers. So, as the market in nursing begins to rebalance, regain some sort of sanity after what we went through COVID, I think that in combination with larger ability to improve pain nursing capacity there are needs there as well.
Right.
That are being addressed. Structure.
Just a quick follow on to Dr. Davis's point. You know, the general consensus in I know a rural hospital is that, well, if you can just get them to the specialist at the secondary or tertiary care center, then they'll be taken care of. But sometimes those, like the tertiary care center is so limited because of lack of nursing availability that even though you may get them there, they can't get them into the operating room or whatever special procedure they might need. And so you really haven't accomplished that much. And so it's a systemic problem. It's not just Mississippi, it's nationwide. But, you know, we need to look at ways in which to at least help mitigate some of the problem.
Yeah, and I'll be honest with you, I have real concern for this winter because capacity is at an all-time low. And if, we got through this bump of COVID without any trouble. But last winter, we were stretched pretty thin with the combination of COVID, flu, and RSV hitting at the same time. And hospital beds in general got really tight. ICU beds got really tight. And I think, Melissa, it may be lower capacity now than even last winter in terms of hospital beds. So, we have fewer staffed hospital beds and ICU beds today than we did, during the Delta wave. So and that's just because the staffing is down so much. So that's a real worry, and we'll just have to watch how the winter goes, which is why I get vaccinated, stay out of the hospital. But those are very, very important points.
We need to keep bed capacity on as a discussion topic as we look at the state health plan.
I mean, for people listening in who don't understand, I mean, there are floors in hospitals with beds, but no one to staff those floors. It's not a need to build another wing. We have great capacity. Physical hospital bed, but a hospital bed does you no good. Now, staff, CNA, not everyone can get their patient. That's the
That's
issue.
right.
That's the issue. Face it all. This perception. We don't have a hospital physically. We don't have staff. That's the crisis. Or you get your work to correct that, and the market's going to play a big role in that. They balance now. Nurses or nurses never takes that.
Yeah, so I do think this enhanced funding, both directions will help, and we definitely have to help y'all. There's a hospital that played a very important role in pandemic response in a underserved area of the state, whose ICU was running 150%, through the Delta and Omicron waves, who no longer have an ICU. That hospital has no ICU beds. And that's the stuff that worries me and we also, right now, I think the state health plan will help us with this. It's really hard to know what's out there unless hospitals tell you. I mean, we know how many licensed beds are out there, but in terms of staff beds and which beds are ICU versus, med surge, I think the state health plan, I'm hopeful that the state health plan put more transparency on those numbers, which are really important. I mean, that's critically important to do any healthcare planning.
I think Dr. Griffin's comment about being sure that the people who get defibrillators have training, even though the statute says they do, is one we need to be sure that those sites are doing that training. All right, any other questions for Dr. Edney? Dr. Ann?
Just one more question. Do we still have a good communication plan to let people know what they're eligible for?
Or in general, Dr. Anthony, or for the AED specifically? um, probably not where we want it to be. But we made some adjustments when we saw the low uptake, relatively low uptake. We made some adjustments on our end and then working through partners to try to push the word out. So, we're gonna push harder.
All right, to push us along, Sharon, the floor is yours.
You don't hear me through the microphone. I just have a quick update on our financial information. Go to the next slide. We presented this next information to the Legislative Budget Committee about 2 weeks ago. They're waiting, wait till it pops up and I'll show you. But just overall, out of our funding, about 5% of our funding is general fund, 80% is federal, and 50% is our other funds like self-generated. So we have a small percentage that are general funds. I know that screen looks very small. So, we have general fund and then what they call other state support, which is tobacco control, healthcare expendable, and capital expense. What this slide is trying to show you is how much of these buckets are used for core agency operations, other health department programs, which means those are items in our appropriation bill that are line itemed out for health department programs, and then the items that are for other purposes. So at the bottom, you can see that out of our state and other state support, 40% is strictly for full public health. You'll see that over half is other purposes, which that's made up of the trauma system, EMS, our payments that go directly out to UMC, those kind of things. Next slide. This is just a visual again, so you can see, most of our money that we've received from the legislature directly is not for our purposes. Next. So for budget year 25, on the very first screen I had, we were asking for about around $10 million more in state general funds in 25. In the previous session, we did ask for an increase for salaries for employees. That did not pass. So this year we're tackling it a little bit different and asking for an average of a 4% salary increase in employees. About 700,000 of that would come from general funds, and the other is just for our authority, which for our new guys, we have to have, the legislature has to give us the authority to spend our federal funds. So we need them to give us almost $4 million in authority. We have the money, they just got to let us spend it. Then there's almost $9 million in general funds that we're asking for to help support our public health nursing workforce in recruiting, salary initiatives, all of that. Because like y'all were saying, we have nursing for shortage and it impacts us as well from the county health department standpoint. And then we're asking for $900,000 in general funds to support the implementation of an OB system of care. I know we brought this up in the last board meeting. So those are our key items. I want to piggyback on something that Logan has said about the Underwood. So it is in 2 phases. So there's a phase 1 and a phase 2, but phase 1 has a phase 1A and a phase 1B. Phase 1A is the pharmacy, and that's funded with ARPA funds. Hopefully, I got my fingers crossed, they said we would have construction documents this month. So maybe, hopefully by the end of the year, they'll be breaking ground onto the build out of the new pharmacy. But with the roof for Dr. Edney's office, it's been going on for over a year. We're waiting for them to sign the contract. We worked through all this with DFA. So that's just it's a process. Hopefully, we'll be having a vendor come out pretty soon to put that new roof on this building right here. Any questions?
Any questions? Mr. Moody?
In the request for salary increase fund, what portion of that can be used for realignment?
It's basically it's an in-range adjustment is what they call it. These terms now through the state personnel board, they call them in-range adjustment. So that's really what it would be. Our current staffing, most likely, we could give them a 4% raise. So it would be realignment.
How many, what part of our agencies, positions do we have that are not filled right now?
Yeah, it's the
way the state personnel board number, our positions through the state personnel board, that pin count, as they call it, is really high because we've escalated a lot of federal grants. If you go by just that number, like Chris was saying, it's probably about 50%. Truly of the real positions we need is probably 20 to 30%, I would bet, that are vacant based on true need. When we get a federal grant, what they call escalate. So in order to get the funds so you can spend the money, and then so that you can get the positions created in the state personnel board, there's the term escalation, what they call it. We have to escalate it. So it makes our numbers go up.
You know, that's part of the evaluation of clinical operations is just because we have vacant pens that didn't equate to need. I have no intention of hiring outside of need. You know, we have need for federal grants that we have to staff for. With our state funded positions, we're staffing what we need, not just filling pens. And the biggest struggle that I have is it's so hard to compete with the private market. I mean, we can never compete with the private market, but it makes it extremely difficult to retain employees when nurses are in high demand, and we just need to be close to competitive, which in many areas we're not close at all. I've this last year focused on trying to get our lowest paid employees up off the bottom, and we had to do that with internal resources since we didn't get funding last year. Y'all need to understand 80% of our workforce are federally funded. So only 20% of our workforce are state funded, but I've got, I can't raise the federally funded and not raise the state. And so it's not big dollars at all to raise the state up so I can put these federal funds in. And I like to remind people that's money that goes, we're paying into PERS. The higher we pay, the more money that goes into PERS. We're happy to do our part to support that, but it's, we need some help to get our state employees up a notch so we can be a little competitive, stop replacing vacancies all the time, and and be able to improve the whole workforce with our federal funds.
Yeah, that was always one of my major concerns is we're using state funds as a training agency for the private sector.
And it costs a lot of money.
And by not being able to realign some of those lower paid positions, that's exactly what's happening to us every day. And when we talk about percentage raises, that just causes you to get farther and farther separated.
So that this is a topic of discussion with other state agencies, especially health and human service agencies. They have the same problems, and it costs us about $35,000 per employee to replace. When we lose somebody to recruit, on board, train, and get them in the workforce, it's not cheap. So it's much less expensive to retain them. But so that and what I'll in the same vein as staying away from the bond language, it's appropriation time. I just didn't talk to them about need, and I'm not asking for any wants. I'm just putting the need out there. This is where we need help, and we are getting. There is some appetite to help us with maternal infant. I've been real pleased with those conversations. Raises are always sticky, but they listen, and I appreciate that. But we're looking for investment into programs to help us with population health outcomes, and I think there's some appetite for that.
All right. Now for the board business. The first item is board regulatory actions. A consent agenda, as you know, is supposed to be non-controversial. We've got 15 items before you. Item 2 it adopts some changes with COVID reporting, which officially de-escalates mandatory reporting. Most of the minimum standards are just some hygiene, of the department. And a lot of these, appointments, come from advisory councils, and are straightforward. So we're looking at these 15 items. Mr. Perry, you had felt like, I was thinking 14, was going to be removed, but y'all did such a good job in the cannabis committee. You feel comfortable going forward with that?
Let me be clear, Lauren her team did such a good job. That, I don't believe the cannabis committee did anything.
So it doesn't look like we have to extract 14,
I
but
would like
maybe
to-
15?
I would like to extract 15.
So, well, can I take that as a motion?
Move to extract item 15.
I second.
All right, there's a motion and a second to approve the consent agenda with the extraction of item 15 for our discussion. Is there any discussion about that? If not, all in favor say aye. Any opposed? All right, so we have approved items 1 through 14, and we're now on item 15, which is before you, our legislative agenda. Mr. Perry, you had said what you were thinking.
So I want to make, I would suggest making 4 changes. One and two, like to the, 2 requests for the buildings. Just sad appropriation for bond authority. I don't think we should be in the business of asking. I say this to somebody who can fund it. Let's let them fund it however they fund it, especially since they've been funding things like this through capital expense fund less. So
I think any questions about that, that seems fairly clear and appropriate. Okay, and
item 3 is, I do think there's a value to the department program to say that our generally should be against substantive changes to the cannabis program in the next legislative session. We just approved pretty significant changes in places, a lot of which is in relation to statutory changes that happened in the last legislative session, which was a year after creation of the program. At some point, we need to just run it. See how things go. Then we need to make changes after that, so be it. But I think that should be our general opinion. And then item 4 is, I think, a placeholder for state health plan changes. Wants to include the EMS. I think that we probably ought to be prepared to have a meeting in December. Hopefully we'll have a initial cut from the consultant, state health plan vision, recognizing that's a multi-month, perhaps multi-year period, but legislative session starts in January. Granted, it's a first session of a new 4-year term, so session deadlines to push back, but more than likely you're going to have committee chairman changes happening around that time. I think if we wait to January 10th, that may be a little too late. So I think that we should have a placeholder for what our legislative agenda will be, both EMS to the extent that it's needed, and first cut at state health plan, set a target for Christmas.
do you feel like the board needs to meet after we do that?
I think that if it could be the legislative agenda, say the consultant goes back and says, here are things that the board can do, here are things that you think may need to do with the legislature. I think that there is a value for having that conversation.
All right, so we'll plan a Zoom, maybe a Zoom meeting to talk about the state health plan.
And I think that's worthwhile.
And
to say
EMS.
EMS. I mean, if you just make the decision, and I completely yield to Dr. Cartman, probably Dr. Edney. But I believe that it will if legislative action is needed, it will significantly increase the chances of it being happening and B, something good. If the board is saying, this is what we think we want to do. And giving a little bit of runway, and Mr. Moody, I yield to you on this. I think giving a little bit of runway to the legislature as opposed to doing it on January 10th.
I'm not real sure that the reauthorization bill is caught by the first deadline. And and anything, any changes that need to be made could be done in that reauthorization.
All right, so we'll plan a Zoom meeting of the board to discuss the state health plan EMS. I think we don't really need that to be in your motion, but if
Just wanted to
you
highlight
can
it
go
as part
ahead.
of the legislative
And
agenda.
we'll plan a Zoom meeting in mid-December. The other thing that he is for action, if we could vote on his request to approve the legislative agenda with the changes where we don't say it has to be a bond issue, but can be other options. And the other item that you had requested.
I just think that if we've done, have to be in the formal thing, I think that generally though, our position should be, let's keep God. Be in a position that our position is that let's not make major changes to the program until we actually have that.
I think that could be part of the change. That what our legislative, we don't call him a lobbyist. Because he's not a lobbyist. But our legislative.
I think unfortunately, according to the code, yes. Yes.
Our legislative specialist needs to say that our Medicare, our cannabis program needs stability, and we don't encourage changes to the current program. We just want to get our feet on the ground and get it operating. All right, so court reporter, you figured that out, right? What you're saying. Okay, so that's the motion to approve the legislative agenda with those changes. Dr. Anthony, do you second that?
I certainly do.
All right, there's a motion and a second. Any discussion? All in favor, say aye. Any opposed? All right, we got that. Our new business. We've involves an applicant agent for COVID-19 Federal Disaster Public Assistance through MEMA. And largely this involves what? Transfer of signatory authority? Can you
Yes, sir.
speak to that?
Yes, sir. MEMA has requested that we do this, that, Jim Craig's retirement, we just need to get new signatories in place with our contracts with MEMA.
So this is giving a transfer of signatory authority to current leadership since Jim Craig's retirement.
Am I interpreting this that we're replacing Jim Craig 1 with 3?
I think it was 5 at the last count.
So is there a motion to approve this? All right, thank you, Dr. Griffin. Thank you, Dr. Anthony. There's a motion and a second. Is there any further discussion? All in favor, say aye.
Aye.
Any opposed? All right, that's everything under new business, unless anybody has any new business they want to bring up. Old business, Mr. Perry, there's nothing really there. We addressed all the cannabis stuff. Dr. Cheney, any updates on your maternal health committee? I know you're planning to start meeting again, perhaps monthly.
Yeah, there was an excellent conference in September in that space, and I think there's an ongoing component to that. I think that's going to be really good. But yeah, we want to get a regular meeting schedule and keep up with what we've done and so forth.
Very good, very good. And great work with that committee. Any other old business that the board has? Is there any need for executive session? There is
No, sir.
none. You see the appendices. It's now time to consider adjournment. Before I entertain a motion to adjourn, I want to remind everyone that there is lunch upstairs for the board and leadership, and that's a good time for us to get together. So I encourage you to that. I think it's maybe from Primos, so that might be fun. We haven't done that before. The audit committee meets at 1 o'clock. All All right, so just be aware of that if you're on the audit committee. Remember that the January meeting is going to be a strategic planning session, board development meeting, whatever we want to call it, but it's largely going to look on our strategic vision. We are thinking about doing that annually, and this will be the first one, so it'll be an important one to be at, because we'll sort of set up our initial plan, and we'll probably start at 8:30, January 10th, and our meeting will probably be at 1 o'clock that day. And do note, we have meetings April 10th, 2024, July 10th, 2024, and October 9th, 2024. I can't really think of anything else. Dr. Edney, anything else we need to bring up before I entertain a motion to adjourn? No, sir. Before I ask Dr. Anthony to give us a motion to adjourn, I do want to recognize her great leadership at Jackson State, and what a hero she has been there.
Mr. Chairman, she's also the new president of the Mississippi Association of Broadcasters.
Since you're very busy, do you mind giving us a motion to adjourn?
I sure do.
Is there a second?
Second.
The deed is done. We're adjourned.